we were just gonna wait for another like 3 minutes, and then we will start. I think people are trickling in right now. I think people are still coming in. We will start in a minute or so. All right, let's get it started. Let's start. Thank you so much. Thanks so much for coming. So it is my great pleasure today to introduce today's speaker, Dr. Mark Wainwright. Dr. Wainwright is a professor and the head of the Division of Pediatric Neurology at the University of Washington School of Medicine. Dr. Wainwright is a native of Liverpool, England. After an undergraduate degree in philosophy at King's College London, he completed an MD and PhD program at the University of Chicago, followed by training in child neurology at Duke University, where he also completed a research fellowship at David Warner's neuroanesthesia lab. He then joined the faculty of Division of Child Neurology at Northwestern University, where he served on the faculty for 17 years. While at Northwestern University, he established one of the first pediatric neurocritical care programs in the country and was appointed as the inaugural Endowed Davy Chair in Pediatric Neurocritical Care. Dr. Wainwright specializes in pediatric neurocritical care and is active in multi-center clinical trials related to these disorders, and serves on the national work groups for the management of cardiac arrest and TBI. He served as the chair of the Pediatric Neurocritical Care Research Group and is a member of the editorial board of Pediatric Critical Care Medicine and Critical Medicine. His basic research focuses on glial dysregulation, particularly the role of astrocytes in the long-term sequelae of TPI, as well as neuroinflammation. His other research interests are focused on the use of big data and cutting-edge computational methods to detect organ dysfunction and deliver precision care in critically ill children. In addition to his busy clinical and research work, Dr. Wainwright is also active in mentoring pediatric neuro-ICU doctors and pediatric neurologists in general. I have personally benefited from reading his continuing article on pediatric neurocritical care, along with other review papers he authored. It is my great honor today to have Dr. Wainwright here to review the spectrum of acquired neurological mobilities and neuromonitoring in the pediatric ICU, and assess the potential of electronic medical record and streaming physiologic data to identify phenotypes of children at risk for neurologic injury in ICU. Thank you so much, Dr. Wainwright. Just one housekeeping point. Please, for the audience, please put your questions or comments in the Q&A section or in the chat. In the end, if you have time, we'll go through them. Thank you so much, Dr. Wainwright.
Thank you for that kind introduction and for the invitation to speak today. I only wish it could be in person. So I'm going to talk about an area I became interested in at the time as a basic scientist, and out of frustration at the challenges of taking investigations in the lab and applying them to improving outcomes for children with acute neurologic injury, and at the same time being struck by the volume of data that are generated in an intensive care unit, which we have at the time little ability to make meaningful use of. So to do that, I'm going to outline the characteristics of critical care neurology in children. I'll discuss neurologic morbidity and critical illness, and that will be the rationale for surveying the literature on our ability to predict neurologic insults in children in an ICU, both a PICU and a cardiac ICU. I'll then talk about the representative examples in this field of combining EMR and physiologic monitoring data, particularly physiologic monitoring data, to try to identify incipient neurologic injury, particularly cardiac arrest. And then I'll turn to a use case and show some of the work that we have been doing for computing phenotypes of children in the PICU and the cardiac ICU with some of our current artwork focusing on congenital heart disease and quantitative EEG. So what's a computable phenotype? Well, the idea here, and this is a nice review paper, is that this is a common research and healthcare definitions that allow, in this model that's proposed here, a library of computable phenotypes, which are attached to a biologically plausible knowledge base and a part of a healthcare system in which these phenotypes can be evaluated, tested, and modified based on their ability to direct research and improve patient care. So the themes here are to use common definitions across institutions, definitions which can be applied for research and clinical care. And much of this is attractive to the field of pediatric neurocritical care, which is a field which affects the outcome for virtually all critically ill children, I would argue. It's all about protecting the brain. And a field in which no single institution can really claim to have identified the single way of practicing to improve outcome. So this idea of using the electronic medical record for a combination of research, collaborative healthcare practices is a really attractive one. But attractive as it is, it's much harder to do than it appears, as I'm sure many of you are familiar with, because the electronic medical record is not designed to support this kind of work. Before I get further into this, and in the context of someone who's talking about the use of the electronic health record, defining a phenotype based on the EHR, I want to make this point, and particularly as a neurologist. We're a field where we pride ourselves on our ability to perform a physical exam. And in fact, it's one of the pleasures of being a child neurologist is the making sense of a chaotic clinical interaction with a child that does not want to be examined. It's an important and essential reminder that just having more data from the EMR is not necessarily a good thing. There are key advances in our field that have been made from the observations of a single patient. Guillain-Barré is a good example. This example on the top right here happens to be from MGH. It's one I've used for a long time because I've been interested in hepatic encephalopathy in children. This is a report from McDermott and Adams describing their observations of recurrent encephalopathy in a man with pancreatic cancer who had recurrent admissions to the hospital, and they had to work out what the mechanism of that was. And they figured out that this was hyperammonemia as a result of an Eck fistula. Eck was a Polish military surgeon who'd asked the same question and created this fistula in dogs back in the maybe 18th, 19th century, I think. But this is a single case report, the first identification I'm aware of the link between ammonia and encephalopathy in liver metabolism. Just a single case, really a core paper. And there are other examples. There's a Fortran example here looking at intestinal malabsorption. So I do not want this to appear to be an argument for that the EMR is the source of all the future of this work. We neurologists, the acute clinical exam and observations from a single patient can also advance this field. So Pete's neurocritical care, and one of the things that became of interest to me is that this is not adult neurocritical care for young people. One of the striking things about it is that the neurologic insults can affect and do affect children with diverse pathologies in the cardiac and certainly the PICU. So the approach of cohorting patients, as one can do in adult neurocritical care, by primary brain injuries, separating them out from other critically ill patients, can be attempted. It is being done, for example, in Texas, but it's really, that's an unusual approach, and really the cardinal feature of this field is that the neurologic injury can affect almost all children in the PICU, and as a field, that's how we need to think about it, really trying to protect the brain of every critically ill child. The pathophysiology is really diverse, and importantly, we have very few randomized controlled trials on which to base our practice. We have a real dearth of data on which to practice. And where those trials do occur, or even on the interventions that we make at each of our centers based on what we believe are the best practices for protecting the brain, the effects of that therapy may take years to assess. And where they are assessed and where we do have those practices, there are a few places that actually have a follow-up neurocritical care clinics for children. So the observation of those patients and the impact even of very, very high caliber care in the ICU really ends at the time the patient leaves the ICU for the floor. And I would argue that all of our practice should be based on the fundamental principles of the best neuroscience of our understanding as that evolves. And what does that mean? Well, if you characterize the scope of pediatric neurocritical care this way, you can think of this as acute central nervous system injury, whether it's traumatic brain injury, stroke, cardiac arrest, infections, autoimmune disorders, through to the chronic metabolic and degenerative disorders. So it's a very diverse set of pathophysiologies. It's not one that conventional pediatric critical care training or child neurology training really gives you, I would argue, the depth of understanding that you need to be able to manage these patients. And what I mean by depth of understanding? Well, the cellular mechanisms that underlie each of these pathologies, whether it's barrier dysfunction, ischemia, reperfusion injury, mitochondrial injury, the compromise of the neurovascular bundle, the neuromuscular transmission, autonomic dysfunction, regulation of breathing. These are all aspects that actually have many things in common with sepsis, ARDS, many other core myocardial ischemia perfusion. These are sort of core mechanisms of injury, but the things that few child neurology programs go into in depth, and being able to extrapolate from these mechanisms to making some safe and meaningful clinical interventions is not something that we're typically taught, we typically teach in child neurology residency, nor can we expect, or we could expect, but nor do I think really many child pediatric critical care fellowships go into the level of depth that are required here to really protect the brain at the level I would argue it needs to be protected. So we have a large unmet need for neurologic morbidity in pediatric critical care, combined with a dearth of data. and an interesting, but very interesting, but very complex underlying cellular mechanisms of injury, which actually share a lot of common pathology with other core critical illnesses. Now, there are a number of centers have addressed this, including Sarah Murphy with your group, who's really sort of, to get at that question, surveyed pediatric neurologists, neurosurgeons, and intensivists to see whether this perception I'm talking about is really shared. And in this survey found that using the marker of whether pediatric critical care medicine programs should make training in peds neurocritical care available to trainees, you can see there's an overwhelming 82% of a large number of people surveyed here felt that was the case. There was some difference in opinion depending on whether you were a neurologist, a neurosurgeon. There was more diversity of opinion, but still the majority of pediatric intensivists felt the same way. So there's a broad acknowledgement that this is a field which needs to be expanded. So I mentioned that there needs to be an ability to take clinical observations, recognition of potential neurologic morbidity in the cardiac and the pediatric ICU, and act on it. And I said further that there was a sort of gap in the things that we are able to do, including the things we are able to monitor. Granted there is a neurologic exam, often overlooked in some of this literature with this enthusiasm for technology. But we have at present a relatively limited number of monitoring modalities and interventions. This is the autoregulation curve you're all familiar with. On the left and the right, though, are the measures for dealing with low cerebral blood flow, high intracranial pressure. We can remove an occlusion, enhance oxygen delivery, decrease metabolic demand by recognizing and treating seizures. And in order to do all those things, in addition to the exam, there's a variety of physiologic measures that we can undertake. If you think back now to the mechanisms I talked about of really the complexity of the neurovascular bundle, the regulation of the blood-brain barrier, the mechanisms of mitochondrial injury and the protection against mitochondrial injury, none of these things really get at those mechanisms. And although I think that's a important gap in knowledge and practice that we need to keep in mind, that's not a topic I'm going to talk about in this particular talk. Here I want to make the argument that if we acknowledge this degree of complexity and need, that we also recognize that the things that we currently do to identify and protect against neurologic injury are relatively crude, although many of them work. So what do I mean by morbidity? Well, we'll start with mortality. Mortality in our field is, in critical care, certainly is lower than in adults, but neurologic injury, neurologic morbidity contributes significantly to it. The outcome in children with acute liver failure is an excellent, simple example of that. It's mainly determined by neurologic morbidity. There have been a couple of studies in this area. This was one now about a decade ago from the University of Pittsburgh group, Bob Clark, Mike Bell when he was there. This was a retrospective review. They took 4,500 admissions just to their PICU, not the NICU or the CICU, identified 78 deaths, and then just did a chart review to characterize what was the cause of those deaths. Here are all deaths of the 78 of them. Of those, just over 60% they identified as being neurologic related. Most of those occurred right at the time of admission, this 51, and they broke it down by cardiac arrest, traumatic brain injury, and a scattering of others. The details of this don't matter so much, just to say of these deaths and at this PICU with a lot of expertise in pediatric neurocritical care, the majority were brain related. We did something similar when I was in Chicago. We looked at retrospectively at all our PICU and CICU admissions over a 8-year period. And there we had during that time, we had a neurocritical care service. So we had automated neurocritical care consults, a group of people for whom that was the focus of their clinical practice, so a fairly consistent practice, and a low threshold for consulting that service. And across that time period, the general PICU mortality, as expected, was around just under 5%, but all the patients who had a neurocritical care consult, the mortality was about 9%, and the other observation was that 20% of these patients coming through the ICU ended up with a neurocritical care consult. And just, the nuances, institutional nuances to this. In this case, we were not consulted on post-op neurosurgical patients. These are patients for whom there was a known or suspected neurologic injury. So how does our management practice? We have interesting, very complex mechanisms of injury, but the way we practice, even recognizing the pathophysiology involved, related to intracranial pressure, cerebral perfusion pressure. In this case, this is for severe traumatic brain injury. They're based on thresholds. These are the most recent recommendations, the update from the 2012. And so there's still debate in this literature of what is a pathological dose of intracranial pressure. In fact, it may even be lower than ICP lower than 20, but we base the practice on thresholds. And the recommendations are suggestions, again, a reflection of the challenges of really producing level 1 or 2 data in this field. Similarly, in the recent recommendations we worked on for resuscitation after cardiac arrest, there's a lot of monitoring, but again, fairly targeted temperature management, ranges, thresholds. I've used this example in talks over the past few years. It happens to be from the Brigham, but it's a reminder that people were thinking about these issues 50 years ago. This was a paper in which they described at the Brigham in 1967, but this was actually a theme in that literature in the early 1960s, having specialized units. And this unit, the paper actually has a figure of how the unit is laid out, where the physicians and the nurses sat. And this was designed to shift, as it says here, from resuscitation to prevention for the need for resuscitation. Really a theme of this work and this talk, but something that people have been thinking about and working on for 50 years. So taking now the theme from of shifting from the recognition of the pathophysiology and the potential for neurologic morbidity in an ICU. What does that literature teach us so far? Well, this is some of the earlier really innovative work from Manley and Hempel at UCSF, trying to characterize the shifts in a patient's state over time after admission to their ICU. And here, in this example, these are patients with traumatic brain injury. They collected 23 patients. They underwent multi-parametric monitoring. From this, they had 45 laboratory and physiologic variables, including intracranial pressure and cerebral perfusion pressure, the usual suspects. And they clustered those. They took 14 of those variables and they just created clusters. Those were not hypothesis driven. And of those clusters, which are shown in red on the lower right there, they looked at which clusters were correlated with good and bad outcome, and showed these are time from the data collection. These are individual patients in each row here. And the key observation in this paper, the novelty of it, is that this is just statistical modeling of clustering of these variables, physiologic and laboratory, and showing the change in the patient's state, if you will, state meaning the likelihood of having a good or a bad outcome over the time of this data collection. We did something similar when I was really beginning to sort of think about and work on this field when I was in Chicago. We took CareView, as it was then, which was our highly unstable electronic medical record, extracted from that all the PICU admissions, extracted from that. All those had intracranial pressure monitoring, and just performed a similar cluster analysis of patients who had a good outcome, poor outcome, that is G-tubal tracheostomy, or died. And example of those clusters are shown here. And you can see that some of them clusters, sodium clusters with intracranial pressure, albumin, interestingly, clustered with cerebral perfusion pressure. I'm not making any claims for any insights or sort of medically actionable data from this, but the lessons from this actually were, this was a very unstable electronic medical record. This was feasible, but very difficult to do, very time consuming. EMR does not lend itself to this kind of work. So if we return now to the theme more in pediatrics, now getting into sort of phenotyping, just one of the other areas of trying to do this is in children with acute liver failure. There's the phenotype, obviously, of the clinical exam. There's the biochemistry of that patient. And we became interested in trying to improve on that by using EEG. And here, this Craig Press, who was a fellow with us in Chicago at the time, took EEGs from 33 children with acute liver failure. We, at that time, are still actually obtained EEGs at the time of admission for all child with acute liver failure based on some of this work. And asked the question whether EEG spectra, as opposed to some of our previous work, which had used epileptologists' interpretation of sort of mild or moderately or severely abnormal, could be used to identify children at risk for progression to hepatic encephalopathy and need for liver transplant or death. So Craig stratified these by changes in age, which hadn't been done before, and then correlated the spectral EEG with outcome. And this is the spectral EEG in this protocol. The EEGs were obtained at the time of admission to the floor or the PICU. Outcome was pretty much what we'd expected, about 15% mortality. The majority survived. And in most cases, the neuroimaging was normal. Certainly, it's, in our experience, rare to have abnormal brain imaging absent a child who's stage 3 or 4 hepatic encephalopathy. And this was the key finding. So this is the spectral EEG on the first day of hospital or ICU admission. So no epileptologist required, it's simply a quantitative measure. The abnormalities on that EEG were highly correlated with the need for liver transplant or death, and also with 6-month Glasgow outcome score as well. That's a relatively crude approach to what I will coming to with computable phenotyping, but now beginning to merge some automated EEG data with clinical exam and biochemistry. The CHOP group, this data shown here, took an analogous approach for trying to predict a neurologic insult. So here they took 20, these are infants with congenital heart disease. They took the epochs of the EEG background in the period preceding a cardiac arrest. And the epileptologists in the group characterized those EEG backgrounds on a scale of 1 to 5, from normal up to severely abnormal. And these are the gradations shown here. Black is the most abnormal. And in every case of the cardiac arrest, this characterization shifted from its stable state into something moderately or severely abnormal within a few minutes prior to the arrest. So although the characterization of the EEG was done by an epileptologist, there were features that certainly could be quantified, and the EEG was deteriorating prior to the actual arrest. We also measured another physiologic parameter which has had a lot of attention. There's a substantial literature on this, is the use of heart rate variability, prediction of whether it's myocardial ischemia or sepsis. This is work from Seeley group at the University of Ottawa, looking at the characteristics of heart rate variability for prediction of patients with sepsis. These are adults, but it's a good example of this literature. So 21 adults screened for sepsis on admission. The x-axis is time from admission up to at time 0, the identification of sepsis. The two lines shown here are the time at which the heart rate variability clearly declines. They used, as shown here, as their approach to this, they used both a composite and a detrended score. This is the composite score, which are multiple measures of heart rate variability. In both cases, they were predictive, but the composite measure, you can see at hour 6 and at hour 2, prior to the actual identification of sepsis, heart rate variability was clearly declining. Returning back now to pediatric critical care, there have been a number of elegant approaches to the identification of cardiac arrest in the PICU. I'll show a couple of those. And I want to make the point in doing this that this is a focus on identifying it's clearly a life-threatening event, but still in many ICUs relatively rare, and although the numbers build up over years, and absolutely something that we need to do a better job at predicting and treating. But this is there's the two converging themes here. One is of phenotyping patients using, for example, a combination of an exam, biochemistry, and EEG and acute liver failure. The other is of phenotype of using streaming physiology to predict a particular neurologic crisis, particularly status epilepticus, recovery from status epilepticus, or cardiac arrest. So this is a single two centers in England, Birmingham and Aston Villa. And here they identified 69 patients from their initial data set for whom they had data available. And they created, they called it an anomaly index using a combination of heart rate, respiration, SpO2, and systolic blood pressure. And this is time 0 was the time of the arrest, and showing an example of their model. And using this anomaly index, they were able to create a model which predicted the cardiac arrest in 63 out of these 69 patients. When they asked a group of pediatric intensivists to review as part of their study, the literature for this, the clinical records for these patients, they were only able to predict the arrest in 4 of the 69. One of the other very elegant approaches to this problem of predicting cardiac arrest in this country is from Curtis Kennedy and colleagues at Baylor. And this was a retrospective study in which they had 103 cases, they matched them against controls. And here they took a really sophisticated modeling approach. They had, first, they combined time series trend analysis data with physiologic variables, along with which were continuously measured, as well as laboratory variables which are intermittently measured. And then they built their models using a mixture of different algorithms, support vector machine, multivariate, and trending analysis. And they looked at how each of these algorithms was able to predict arrest in this series of over 103 patients. And this combination of these three models was best able to predict it. So this is an excellent example of the application of particular modeling techniques, their combination and a combination of multivariate and trend analysis to predict this insult. So one of the so that's for sort of all comers in a PICU. If we now try to focus on a population in which we know that there is neurologic morbidity, that the neurologic morbidity may be present for a lifetime, and that there are probably modifiable factors in the ICU, both pre and post-operatively for optimizing brain protection. There's clearly a congenital heart disease population. And this is just to make this slide to make the point from this review paper, this summary from Marino and colleagues, that most of these patients, I mean, it's nothing new to this audience, 80% survive. But of the survivors, the neurologic morbidity in multiple domains, whether it's language, executive function, motor function, visual perception, is a lifetime issue. And that is a combination both of parental factors, the environment to which the children discharged, their preoperative factors, and intra and early postoperative factors. And some of those are modifiable. And so just going to comment on a couple of areas in this literature, and then I'll show some of the things that we have been exploring. And so a paper which had a big impact, I think, on the field, certainly in our practice, was this study from the CHOP group, using continuous EEG monitoring as their standard practice for infants with congenital heart disease after surgery with cardiopulmonary bypass. They identified electrographic only seizures in 8% of this population. And importantly, of those patients with seizures, among those patients with seizures, mortality was significantly higher. So for us, when I was in Chicago and here in Seattle, post-op operative continuous EEG monitoring is our standard practice for high-risk infants after surgical repair of congenital heart disease. The EEG monitoring is clearly not the only monitoring that can be done and is done. So we don't use NIRS, or rather, we've not used NIRS as part of our research yet, but this is there's certainly a literature on this. This is an example from University of Virginia, where here they had an interesting question. They had 62 neonates with congenital heart disease, and they asked the question, if heart rate variability is the decrease in heart rate variability is a predictive factor for whether it's cardiac arrest or onset of sepsis, could the decrease in the cerebral oxygenation index measured by NIRS, could the decrease in variability of that index be associated with poor outcome? And this is a representative example here. This is the cerebral oxygen index trend in the patients with poor outcome. This is, I can't recall the exact interval of outcome, but it was beyond hospital discharge. And you can see a decrease in variability compared to those with good outcome. I'm not going to present your own research to you here, but just to acknowledge your contributions here to this field. Using NIRS, this is using frequency domain NIRS combined with diffuse correlation spectroscopy and pre and post-operative measures. This is a recent paper from a group at Mass General. And here, they're comparing the different cardiac phenotypes. Only in the infants with a single ventricle was lower preoperative cerebral blood flow indices present. So I'm not going to go further into NIRS, but I wanted to acknowledge that literature as well. So we're now at the point where we have, I've argued that most children in a PICU and a cardiac ICU are at risk for a neurologic injury. That separating children with primary neurologic insults into separate cohorts, as one can do with adult neurocritical care, is feasible in pediatric neurocritical care, but not desirable. I've also argued that there is, or shown, I think, that there's a literature, a way of phenotyping patients using a combination of whether EEG, NIRS, and to some extent the clinical exam. But a lot of that literature is really focused on predicting an event, whether it's cardiac arrest or status epilepticus. What one would like, I think, in our field is to be able to phenotype patients on admission to the ICU to identify patients who are at greater or lesser risk of neurologic injury. And that means you have to apply this approach to all admissions, not just to the patients who have a stroke or a traumatic brain injury, certainly in pediatrics, I would argue. Well, there are approaches to doing this. The field of sort of phenotyping, if you will, is really exemplified in sepsis, and the patient, you can classify patients with sepsis by the criteria, but each of them behaves differently, and they're of interest to to pediatric neurocritical care, because one of the things I talked about early on was the mechanisms in sepsis, mitochondrial dysfunction, barrier dysfunction are common also to pediatric neurocritical care. So an example of this kind of approach is using group-based trajectory modeling, taking patients who met these criteria for infection, treated with antibiotics, and looking at trends in their temperature. And in this group, we had a development and a validation cohort, and this is using this technique to look at with no a priori hypotheses. They looked at just using group-based trajectory modeling to look at examine whether there were different cohorts within these 12,000 patients in terms of how the temperature evolved. And they characterize this as people with fast resolvers, slow hypothermic, but fast resolvers, hypothermic, but slow hypothermic, and normothermic. And then found that the mortality was higher in the hypothermic patients. There's a similar approach being taken. This is University of Pittsburgh group. You can do this. I made the point before that practicing based on thresholds is likely recognized as really suboptimal in pediatric neurocritical care in general. And this is data from the University of Pittsburgh, where they looked at, they use again group-based trajectory modeling to look at trends in intracranial pressure in adults with severe TBI. And again, the patients separate by cohort. Some have high to begin with, they get higher and then decline. Others are low and have a late rise, and they classified them this way. Groups 3 and 4 here, those with intermittent or frequent spikes, had the best outcome as measured by mortality and 6-month outcome score. So now you have a theme that sort of recognizes what we know clinically, that just treating a single intracranial pressure, cerebral perfusion pressure, blood pressure, temperature, it really does not do justice to the complexity of the physiology and the individual physiology of each patient. So we started to think about this and have been working on this, taking this approach. We need to identify from all ICU admissions which children are more likely to have neurologic morbidity. The byproduct of that is we'll be able to use those tools to look at other organ morbidities as well. And we decided to start with that using the pediatric SOFA score. This is work from Nelson Sanchez Pinto, then at the University of Chicago, who modified the SOFA score to use age-adjusted cutoffs for cardiovascular and renal function. You can see these are modified by age for renal function and blood pressure. It's a combination of, granted the neurologic exam is a Glasgow Coma Scale score, but it's a combination of cardiovascular, hematologic, respiratory, and renal function. And he showed in this study that the maximum P-SOFA score, this is over 28 days of ICU admission, was significantly associated with mortality. In the scores I'm going to show you, just for some context, the majority of our patients have an admission P-SOFA score in this range, or at their sickest, around 9 to 12. And that's because this scale is based on the worst of 28 days. So here's the idea. The idea, and there's nothing novel about this, it's just the idea was we would be able to take every ICU admission, apply some validated risk scores from the literature. We focused on SOFA. That gives you from that, it gives you you can cluster patients then into low or high risk for particular organ dysfunction or outcome. You have identify the patient's phenotype, if you will, on admission, in addition to the clinician's impression. There, combine that with the physiologic monitoring along the lines of what examples I showed you from the literature, and I know that your group in particular is familiar with and has led this field in. And then combine the physiologic monitoring data to define shifts in the patient's state. And you can define state, whether it's based on an organ injury or likelihood of a particular long-term outcome or response to a particular therapy. Then combine those data with relevant long-term outcome data, and all these data get fed back into, you have a continuously modifiable model. Nothing innovative about these ideas, just much harder to do than it is to make a figure like this. There's a variety of ways this has been attempted, some with commercial software. This is our structure. I just want to make the point that two things from this. First, that I'm going to show you clinical examples, but to get to this point, this is a data engineering problem. One of the key messages, I think, from this work is that we can build models, we can apply AI and machine learning, but that, I would say, is the easy part. The harder part, the core of this, is having the engineering skills to be able to extract these data from the EMR in ways that are actually you're getting the right data and remove the wrong data. And that requires a collaboration between engineers, analysts, and physicians. And that is not that common. Anyway, this is our structure. I'm not going to go into it. I'm glad to answer questions about it later. But it's really is to make the point. This is all off-the-shelf open source. So this is our data. So unpublished, these manuscripts are in preparation. This is work by Alex Dowd, who's a neurophysiology fellow at the University of Washington. So we took all the PICU admissions for which we had data, 16,000 of them from about 2010 onwards, extracted the data and looked at the changes in the pediatric SOFA score over 7 days. We used seven days. Not all these patients were admitted for 7 days, and this is using group-based trajectory modeling. And of that, once we fitted those data, a model with 7 cohorts fit best, and they're shown here. This one, these are patients who were sick on admission, and they remain quite sick. Others, there's a cluster here, they have a pediatric SOFA score of around 6 or so. Some get better quickly, others tend to stay sick. This is groups 1 here, 1-4 to make it easier. Mortality is highest in groups 1 and groups 4. And what are the other characteristics? Well, there's the variable use of EEG, which in our case is a surrogate for a neurocritical care consult and involvement. I'll go into that a bit in a moment. But we've also worked on one of the struggles in this field is how do you know the difference between a patient who's getting sicker by whatever analytic methods you use, as opposed to getting sick and getting sicker despite escalation in therapy. So for this, you really need to know what's being done to the patient, not just the procedures, and getting the right timing of procedures is a challenge in itself, but the drugs that are administered. And those are shown here, the antibiotics, vasopressors. You can see that this is, all these data are median and interquartile range. We classified them by antibiotics, anticonvulsants, and so on. This is the ability to get these data is an example of one of the challenges in this field. This is not just about modeling. It requires clinical judgment, and it also requires this collaboration between physicians or clinicians, engineers, and analysts. The product to produce these numbers required this. This is row 6,700 of an Excel spreadsheet containing every drug administered at Seattle Children's. Every one of those drugs has to be classified by hand into something that is meaningful to enable an analysis like this. But some of them are wrong. Some of the names are absurd. You'd never find them. And I can say this 6,700 rows because I did every one of them. So to go back here. So now if we focus on this population, patients on EEG, a surrogate for neurologic injury or concern for neurologic injury and neurocritical care involvement, we take that cohort alone and then separate them again out by SOFA score. See a very similar pattern actually. 2 groups with high mortality. And the characteristics don't matter so much. I want to show you sort of principles of this now. We've looked also of these characteristics, groups 1 here and groups 4. We are able to extract the physiologic monitoring. These are, interestingly, these are the monitoring data and the lab data from the first 48 hours of admission, because some of these patients did not have a full 7 days of admission. So we have 2 groups of particularly high mortality. We have the Cornell assessment of pediatric delirium scores in the first 48 hours are actually quite high, higher than the threshold of 9, which is emerging as the threshold for defining brain injury in critically ill children. And looking at shock index, rate pressure product, there's no obvious differences there, although that work is still ongoing. So I want to make sure I leave some time here. If we now turn to the cardiac surgery cohort, so here, this is a group that is really really important if you're interested in brain protection. I mean, it's one of the most challenging areas, I think, of pediatric neurocritical care. Infants who may have preoperative brain injury, they have a vulnerability to white matter injury. They have an outcome that is a function both of that vulnerability, the injury to the white matter, and both their parents' mental health and the environment into which they're discharged for years later. And the neurologic morbidity affects multiple factors of their lives in really meaningful and detrimental ways. So it's clear that there's no intervention that we would make based on the kind of things I'm going to talk about now that would prevent all of those things. But if we're going to pay attention to neurologic monitoring, it makes sense to think that just having seizures alone is probably not really recognizing the true injury these infants are exposed to. So based on the 9 paper I showed from CHOP, we've had for a couple of years now a protocol for routine postoperative EEG monitoring for all high-risk congenital heart disease patients postoperatively. They undergo that monitoring for 48 hours. If the EEG looks okay, there's no neurocritical care involvement. But if the EEG looks abnormal, or the seizures, or there's any concern from the cardiac intensivist, there's one of the neurocritical care group sees the patient. And that's important because that's what this means here. So we took these 108 patients, underwent EEG by protocol, just characterized them by the pediatric SOFA score, all begin quite sick. This is the postoperative score. These are 7 days, the first 7 days of cardiac ICU admission after surgery. And the values shown here, you can see in group 3 here is the highest mortality. Also a group where we separated them out into patients who were actually seen by neurocritical care, meaning there was some EEG abnormality and or some concerning aspect on the physical exam. And we found even in the highest mortality group, when we characterized the laboratory and physiologic measures, rate pressure products, shock index, blood pressure over the first 48 hours, at present, no significant differences between groups, although this analysis is still ongoing. I really want to make the point that we can get these data, we can clean it up. Now, so what about brain monitoring? This is work from Alex Dowd. One of the challenges with this work is if you take the EEG, other quantitative cardiac measures like heart rate variability, the idea of what's normal doesn't really apply here. You have to normalize, but the goal is for the patient to be in a stable state. There have been a variety of approaches to this. So here, what Alex did was to use EDCF to separate out the patients. These are the neurotypical patients, of which there were 65 in this cohort. We excluded those with abnormal, with known genetic testing and abnormalities, and then separated out those by analyzing by alpha delta ratio, theta power, and heart rate variability, using the low frequency, high frequency power into those who had a confirmed neurologic injury, that is seizures or stroke or hemorrhage, versus those who did not. This allowed us to look at the distribution of these values. And so we could now characterize where each of these patients fit into that range. And so now using this approach, this is the cohort of patients with and without neurologic injury, in this case, stroke or hemorrhage actually. This is the x-axis here is the time course after surgery. You can see, and this is between the 5th and 95th percentile. In every case, those patients who went on to have some vascular insult had lower alpha delta power immediately after surgery. We don't know when these insults occurred except from seizures. So this is not an example of trying to predict a particular event at a specific time, but again, phenotyping these patients so you can identify their risk. Again, if we did the same thing for cerebral ischemia, similar pattern. Early on, there's a lower alpha delta ratio, and strikingly with heart rate, low frequency, high frequency ratio and heart rate variability, this is the 5th and the 95th percentile. This is the patients with no injury, again, time after surgery, and those with ischemia. Again, early on, there's a separation of these two groups. I'm not going to go into that. This is similar trend for seizures, although there's not quite so definitive. And and again, this is these similar separation for heart rate variability with and without seizures. In each case, you can see, for instance, with and without seizures, the alpha delta ratio, this is the theta power, is lower in the patients without seizures as well, with seizures. So I've argued that computational approaches are possible. They, I think, are valuable, but they really need to be collaborations across multiple institutions. I think phenotyping is, in the end, it requires medical decision making, but it begins as a data engineering problem, and it has to be medically plausible. And the corollary of that, not often discussed in this literature really, is this requires both collaborations across institutions, but also across fields. The engineers, analysts, and who really operate in silos, and in order to be able to make use of these data, that meaningful use, safe use, in addition to one's clinical exam, really requires rethinking, I think, how we approach medical training as well. And I'm going to stop at this point and thank the people who've done all this work. Alex Dowd done all the quantitative EEG and heart rate variability work. Yang Li did the group-based trajectory modeling work, supported by an outstanding team of engineers here at Seattle Children's, and this was our support. Thank you very much.
Thank you so much, Dr. Wainwright. So we have some questions here, and please put your questions in the chat or the Q&A section. So the first one is from Dr. Bay Moswi. So he asked, is pediatric neurocritical care a consult service or a dedicated unit at Seattle Children's? Are there many dedicated pediatric neuro ICUs in the States?
Yeah. There's only one dedicated pediatric neuro ICU, that's at Baylor, run by Jen Erklauer. In all the other programs I'm aware of, they're a collaboration between critical care and neurology. And for Dr. Staley's question, there's an overwhelming number of false positive alarms from low-tech monitoring of heart rate and respiration. Yeah, for these new predictors of catastrophes, which are likely to have useful positive predictive values. This is another important question. Alarm fatigue is really important, and we do not want this to build another alarm. I would answer that in a couple of different ways. There are some approaches like etiometry, the IDO2. You have a predictor of hypoxia based on very carefully done research. You still have to act on that, but that's one approach to this. Another is to think that perhaps the goal should be that we don't have to predict a particular event. What we need to do to begin with is identify a patient who a reasonable experienced clinician would think that patient needs a little bit more attention at the bedside, whether it's from the nurse taking a look at the patient or the team rounding earlier. And I know that begs the question really of developing tools which are also biologically plausible and identify mechanisms of organ injury, which also identify a mechanism that is immediately remediable. So anyway, this is our circuitous and rather long-winded answer to say, I completely agree with the risk here. And I think it's a combination of just heightening awareness, and in some cases having perhaps having a definitive tool for certainty of some organ injury. Not at that point yet.
Great. Thank you so much, Dr. Wainwright. I think we're running out of time. So thank you so much for teaching us today.
My pleasure. Thank you for your attention.
Yeah, thank you. Thank you for coming. Bye.
Yep, cheerio.